next speaker is Dr. Rob Welch, class of '93. I'm having fun introducing people, but it's really fun to introduce one of my classmates. Rob is a professor and academic interventional cardiologist at the Mazankowski Alberta Heart Institute and the University of Alberta in Edmonton. He's the director of adult cardiac catheterization and interventional cardiology program, co-director of the University of Alberta chest pain program, co-chair of the Vital Heart Response, a regional reperfusion program for the early treatment of STEMI patients, and co-chair of the Mazankowski Alberta Heart Institute transcatheter aortic valve implantation program. There's lots more here. His clinical research interests are focused on the management of the full spectrum of acute coronary syndromes and interventional cardiology in general. Other research interests include diabetes and cardiac physiology. He has published over 100 peer-reviewed articles, several book chapters, and greater than 100 scientific abstracts. In collaboration with colleagues, he has received a CIHR CMAJ Top Canadian Achievements in Health Research Award. Nationally, Rob serves as the Prairie Province's representative on the executive committee of the Canadian Association of Interventional Cardiology. I'm going on to page 2 now. He's on the Prairie Province's representative, or he is the Prairie Province's representative for the American College of Cardiology Board of Governors. He is co-director of the annual Cardiovascular Congress in the Rockies. He initiated and organizes the Heartbeat Run to raise awareness of cardiovascular disease and risk factor management and raise funds for the local hospital foundations with events in Edmonton, Calgary, and here in Saskatchewan. So Rob's talk is entitled Contemporary Management of Acute Coronary Syndrome. Rob, welcome.
I promised, they promised to heckle me, so this could be ugly.
There's one in particular.
So you learn many things at a meeting like this, and some of them are quite surprising. So a little 7 degree of separation discussion before I get into my real presentation. Dr. McClure lived 2 doors down from me, and he's passed, I presume, you know, and his wife is still, you know, doing reasonably well, but they've talking about selling the home and moving on now. But the thing that really surprises me is the humility. Besides the fact that he likes Scotch, which him and I shared intermittently, I had no idea of some of the accomplishments he's done. So it's nice to know people like that in our world and life and dedicated to the needs of others. I'll tell you that I completely rewrote my talk this morning. As I looked at the audience, I thought I was going to kill you guys with data. So I'm going to try to walk you down a story and really talk about the intersection of process and content of care, something that I've focused on over the last kind of 15 years. I do have a lot of disclosures because I work extensively with the pharmaceutical industry to do the trials we do. Pharmaceutical industries, just to come back to one of the questions that was asked earlier, don't receive funding from the government, to be very clear about that, but they do receive tax breaks if they do research in our country. So there is some motivation and some win for us. And because of the research I've done, I also do talks and sometimes receive honorarium. And then the pictures around that are my real conflict. My playground is a cath lab. I'm the guy that accounts for that top of the budget, putting in valves in people, putting in very expensive stents, and really dealing with the acute care. The beauty of medicine is we can all choose where we fit in this spectrum from very acute care to very chronic care, and that's what makes our job so special. What I'm going to try to do is really walk through 2 different journeys about incorporating clinical research into clinical practice, a research journey to start, and then a clinical journey to validate those research, so taking it to clinical practice. And then something I'm very passionate about, and I hope some people in this room may bug the government about, is the next concept, which we'll touch on very briefly, and it's a concept of randomized registry clinical trials. And I'll talk a little bit about that when we come back to it. But I think that is the future of clinical investigation and something that we can do in Canada that's hard to do in many other countries in the world. So the speakers this morning really laid out this part of the talk so that I don't have to spend much time here. But cardiovascular disease accounts for a large proportion of mortality for both men and women. Of cardiovascular deaths, about a quarter are related directly to heart attacks, so the topic I'm going to hit on the most. And when I was in training, Bob Roberts, who's quite a famous guy in the cardiology world, came out and basically told me by the time I was done training, there'd be no work because they were going to figure out the genome. When they figured out the genome, they were going to directly target disease states and get rid of cardiovascular disease, and I wouldn't have a job. What we've actually seen is the exact opposite. With the obesity epidemic that's been talked about, diabetes epidemic that's been talked about, we've actually seen a plateau now, and longevity is not increasing. It was increasing almost at 1 year every year in the past, which means, of course, we'd all live forever, right? It's a beautiful concept, but it didn't quite work. But now we're actually dealing with the other end of the spectrum, and almost every country in the world, if you look, about 9 out of 10 Canadians have at least one cardiovascular risk factor if you go through the 9 typical risk factors we talk about. So that's a disease state. I put this slide up to remind myself and you guys that this is a continuous spectrum. We've heard great talks about exercise, primary prevention, incorporating all these different strategies, but this is a spectrum that starts in your teenage years. That's a scary thought, but it's absolutely true. Autopsy studies of 18-year-olds already show evidence of atherosclerosis. Those were done on soldiers that you could argue may not have the healthiest lifestyle, stressful situation, smoking, but in other ends incredibly fit and fed a relatively, at least I wouldn't say nutritious, but consistent diet in the Army. And then what I'm really talking about is the end concept when you actually occlude the artery and have a heart attack, the acute end of this spectrum. So I'm going to tell you a story to set the stage. This is Mrs. MW. She was a 75-year-old healthy farmer, presented with an inferior wall heart attack to a local community hospital, Melfort. Many of you will know that, obviously. She really toughed out this heart attack at home, kept doing yard work, didn't come in, presented about 11 hours and received streptokinase. It was a low-risk infarct. She was very stable. She was transferred to City Hospital, deteriorated, short of breath, pulmonary edema, and was brought to the cath lab. This is when I was a medical student in my final year and had a diagnosis of acute VSD post-STEMI and actually wasn't considered a surgical candidate and died. This was my grandmother. So you go the whole full circle of where we start and where we end, and I'll tell you about time to treatment and what we've tried to do. So if you look at mortality through the years, before simple things like CCU, where we shock people out of VT and give them morphine for pain and nitroglycerin and Lasix, heart attacks had a mortality of 30%. 1 in 3 people died. Simply by giving those simple therapies, we cut that mortality down to 13%. So the simple things made a massive difference. And then in the current reperfusion era, where we open the artery that's causing the heart attack, we've lowered mortality, at least in clinical trials, as low as 6%. But if you look in registry data at the time we made this slide and published it, the registry data showed that it was much more closer in an all-comers population to a 15% mortality. So more than 1 in 10 people that have an event actually died from the event. And the single most important thing in decreasing that risk was time, okay? So this is a very famous philosopher. For those of you who can't read the bottom, it's Jean-Luc Picard from Star Trek Generations. I'm not a very complex guy. I'm kind of simple, so I go to movies, not true philosophers. But basically, it's a very fitting story to heart disease, at least in the setting of heart attack. Time is a companion that goes with us on a journey. It reminds us to cherish every moment because it will never come again. The basic concept is once you kill heart cells, they are dead and they don't recover. At least we haven't figured that out yet. Experimental models show that you start having irreversible damage in the heart muscle within 20 minutes of coronary occlusion, and by 6 hours, at least in an animal model, all the damage is done. How does that look clinically? I don't want to kill you guys with data as I've stated, but if you look at the benefit of treatment, that's what this graph shows by time. In the first hour, you save twice as many lives by giving reperfusion therapy as the second hour. So that tells you how important time to treatment is. And then it's a continuous decay in the benefit, although there is still benefit even if you treat late. So one of the opportunities I realized very early in my training, I was still a fellow in interventional cardiology when we implemented this program, is why do we bring the patients to the therapy instead of taking the therapy to the patients? Why do we not take clot-busting drugs in an ambulance and deliver them to the patient instead of having the patient drive in. And this is really important for small communities that are a long ways from hospitals. So it was a simple concept that really hadn't been investigated in Canada. The French system, which I'm showing you a picture of one of their ambulance systems, had been doing this for years. But the difference was they had physicians in the ambulance. So the question we had to deal with in Canada is, can we deliver pre-hospital care for heart attack patients in a paramedic-based ambulance system? Can we take this care and deliver it? So I had a chance very early in my career to get involved in a trial. The trial name doesn't matter, but it was an international collaborative that was looking at delivering pre-hospital therapy for heart attack, randomized to 2 different anticoagulant strategies. The content doesn't matter, but the content that matters for this discussion is that of those sites, we were a major player. We were the largest enroller in this trial. There was 65% of patients enrolled in sites with a physician, and the others were enrolled in sites with a paramedic-based or nurse-based team like ours, and ours was a majority of that. So one of my early publications looked at the impact of having a non-physician-based system versus a physician-based system. We looked at simple markers like time to treatment, and it's broken into the different segments of time. And our paramedic-based teams did as well as physician-based teams, or arguably better. So conceptually, this may sound like the docs are slow, but you also have to realize that in Paris, where most of the physician-based teams were, there's a lot of traffic, driving issues. If any of you have ever been to Paris, it's a nightmare to try to get around, especially in the middle of the day. Whereas in Edmonton, we had a much larger cadre of paramedics in the field and less travel distance, so there's some shortness there. And our paramedic colleagues are incredibly good at following checklists. If you tell them to do 1, 2, 3, 4, 5, 6, 7, they do 1, 2, 3, 4, 5, 6, 7. Whereas we as physicians like to stop and think about what we should do. We're not quite as good at following rules. We like to contemplate and debate the risks and benefits. So we showed a faster time to treatment with our paramedic-based systems. And if you want to know hard outcomes, and it may be hard to read all of those, basically there was no increased risk in any of our paramedic enrolled and treated patients, and the mortality and the hard endpoints looked very similar. If anything, a lower risk of major bleeding and a lower risk of intracranial hemorrhage, the 2 major things you would worry about delivering this therapy in the field. And the other thing we tracked was something called masquerading MI, which basically means you treated a disease that wasn't a heart attack. So pericarditis, aortic dissection, the things we worry about. And our paramedic-based system was actually 2% lower at mistreating patients. Now, when I say paramedic-based system, just so you guys don't get confused about what I'm talking about, because I didn't go into all the background, they transmit the ECG to someone like me who's on call. I interpret the ECG and help them make the decision by talking to them in the ambulance. So it's a direct communication. So it's not independent. It's physician-based, but remote physician-based. And we've built a system now where I can take a call anywhere in the world. I took some of the calls for this study in the beach in Cancun. Like, you can do this remotely, truly remotely. So it's a great process. That led to a trial that we did here in Canada called West. You don't need to know the details, but it really looked at the next step of how we can improve clot-busting drugs by linking them to the cath lab for patients that don't reperfuse, which happens in about 30%. That moved on to a much larger international project called the STREAM study, which we've just published in the New England Journal of Medicine. And it's, I think, changing slowly some of the concept in the cardiology world. There's a huge ongoing debate about primary PCI, so opening blocked arteries with balloons versus using clot-busting drugs. And if you looked at the results from our trial, which were based on that and the discussion, we really wanted to test the concept of early fibrinolysis within 3 hours of symptom onset, with opening the artery with a balloon if the drug fails, but then a conservative approach if it doesn't fail, where you go to the cath lab in a much more controlled manner versus primary PCI. And if you have heard about this, most of you would presume that primary PCI is the best strategy and the one that would win. The outcomes were actually, it's a smaller trial, so they weren't definitively different, but the clot-busting strategy delivered early, mostly in ambulances, actually did better than primary PCI, going against most guidelines internationally. So a somewhat controversial paper, and there'll be much more data coming out of this. So that was an attempt to walk through proof of concept. We can do this in the ambulance with paramedics. to an early Canadian-based study and now to a larger international study, which has really established some of the things we've done. So translating research into practice is what we received as a group that CIHR award for, because we took our research interests and actually built it into a clinical program. So we used research to build the story, then we developed something called Vital Heart Response. And these programs need names. I'm not sure it was the right name, but it has a nice acronym, VHR. It's easy to remember. And basically it was a regional-wide systemic approach to the treatment of heart attacks, which incorporates what we learned in research. Initiating therapy in the ambulance, driving it through a system-based approach, and guaranteeing a quality assurance program and feedback mechanism to ensure you're doing a good job and get better in the future. But there's always a reality check. So what did we do, and have we done anything interesting in our clinical program? And I'm not sure if you can read that, but this is about how I feel when I go to the banker sometimes to buy that fancy car or upgrade my house or whatever I've done. And I'm told he has insufficient assets to fund his reality check. So that's a bit how I feel some days. So the Vital Heart Response was really built around delivering best therapy at the best time in the best place. And this quote at the bottom was one that we came up with our group, and we really felt we were at the juncture where medical knowledge had established excellent treatment options, and now we really need to practically implement them and actually deliver the care that we know about from research. This slide puts out the entire program on one piece of paper or one figure. You have a patient in the middle. We judge that patient's risk, if it's a low-risk infarct or a high-risk infarct, and their bleeding risk. We look at the time from symptom onset to when they can get therapy as a big determinant, and then we actually deliver therapy either in the ambulance, in the tertiary care center where the majority still get primary PCI, obviously, or in a community hospital, and then we interchange patients between these centers to try to deliver best care. The key elements of a program like this is that you really need service integration. You cannot have competitive sites fighting for patients. You must work together with a common goal. You must have a supportive infrastructure with some human resources and be able to educate a large group of people. We train 500 plus paramedics to do this and continue to train them. And you need a quality assurance program, performance assessment to get better in the future and ensure you're actually delivering the care you think. And as a researcher, this is a direct access to publishing your results, so having a good QA program. We started off with the province only treating patients in the Edmonton region, but right from the start, I had a strong commitment to rural patients. I'm from rural Saskatchewan. I grew up in rural Saskatchewan, and I saw the discrepancy in care between where I lived versus the cities, and it's something we focused on early. So we expanded to key centers early on in the phase of this program. And those blue circles are regions where the ambulance system had the capacity to deliver this care, and then the rest of the province wasn't covered early on. And about 3 years ago now, we've expanded to cover the central and northern part of the province, where basically every ambulance unit driving, if you phone an ambulance, they have the capacity to deliver care in the ambulance through the whole province, plus all the small hospitals. I don't know if there's any rural family docs here, or if there or any retired family docs here, but you make tough treatment decisions, and you may see one STEMI every 3 years, 2 years, it might be a rare occurrence. The way we've built our system is you make one phone call and you get a direct access to one of 5 people that work in this program I've built. The ECG is transmitted automatically by the nurses, and we make immediate decisions. So we're really trying to help the rural patients. You hate to brag, but I need to brag just a little because this is the last decade of my life. I don't know what I'm doing the next decade, but this is the past decade of my life. This green dot is my region. That's Edmonton. This second dot beside it is northern Alberta. The orange bar represents the average adjusted 30-day mortality in Canada. And Edmonton is the only region that's got a significantly lower, statistically significant lower. It's become stats versus clinical difference mortality with heart attack. But the point estimates of our northern group, our rural patients, actually look just as attractive. And for those of you that don't do stats, the size of the whisker plot just means smaller number of patients, therefore you're less confident in the data. And the tighter the bars or the whiskers, we call them, the more patients and the more consistent or more believable your results are. So we're quite proud of that. But we also, through the quality assurance program, had a chance to look directly at our real rural patients, not CIHI's data, but our own data, and how they were treated. The purple bar is urban patients, so basically Edmonton. The kind of red bar is patients that come from rural communities and how they are treated. As you can imagine, in the city, the vast majority of our patients go direct for primary PCI, and in the rural regions, clot busters are standard of care. The same number of patients are not treated in both cases, which is good because, rural patients tend to get more delay and less likely to get treatment. So I think our system has removed that discrepancy between rural and urban patients. And then if you look at outcomes, again, I don't want to kill you with numbers, but if anything, our non-metropolitan patients, which are a little bit younger, do better than our in-city patients. And when we do all the statistical adjusting that you can, that's a consistent finding. So interesting stuff, and we've published this with a student in the Canadian Journal of Cardiology this year. So we've made that difference for the rural patients. And then I want to introduce one other concept that we've addressed, and our center, really with the leadership of Paul Armstrong, has been instrumental in establishing as a concept. So this is a real patient, 65-year-old male, no past medical history, presents with 1 hour of retrosternal chest pain. He calls EMS, the ambulance arrives in 7 minutes. That's our standard arrival time. On scene, he's quite hypertensive, a little bit tachypnic, breathing fast, positive S4, no murmurs and scant crackle. So he's got early heart failure. So this guy's fairly high risk. His ECG, if you look at it, is a relatively large anterior wall STEMI. They phone our system. He gets clotbuster in the ambulance within 90 minutes of symptom onset. By the time he gets to hospital, he's completely pain-free. His ECG is normalized. The next day, his CKMB, his heart enzymes that show heart damage, is only mildly elevated. His echo is entirely normal. He has a cath done that shows a small residual stenosis, and he goes home within 3 days and has no evidence of heart damage. So this concept of an aborted myocardial infarction, we heard a discussion about abortion from another termination point of view this morning. This is a very good thing, where you leave the hospital after a heart attack with no evidence of heart damage, a concept called aborted myocardial infarction. And if you just throw up the numbers, the words, this is what's important. If you abort your heart attack, obviously you're much less likely to die. If you deliver treatment within the first hour, 1 in 4 from clinical trials, 25% of patients leave the hospital without heart damage. So once again, within our quality assurance registry, we had a chance to look at this, and our numbers are actually even a little bit higher. In that first hour of treatment, over 30% of patients leave the hospital without heart damage, and there's a continuing decay, but still a consistent about 15% of patients have no evidence of heart damage when they leave hospital. So delivering early care greatly reduces mortality. Many different ways of showing this as part of that combination of using clinical trials and then quality assurance data to make sure you're doing a good job. So now this is a mountain that I love to camp at. It's a place called Mosquito Creek, and I hate mosquitoes. Don't worry, the mosquitoes aren't bad there. It's too darn cold. But it's sitting there, and this is the moon in mid-afternoon setting over Hector. So this is, I call it moon over Hector is one of my pictures. But this new concept is a bit like that, the moon in the daylight, and how are we going to move forward. The concept, so you understand it, is that you can use registries. So I have access to registries, and you can actually randomize patients and then track them through the registry as a way of performing clinical trials with very little cost. And you guys may all say, well, we don't have access to registries, but the truth is the government tracks outcomes on every single patient. They track repeat hospitalizations, they track everything you need to know to do clinical research. And if they give you access to that data, something we're fighting hard for in Alberta, you can actually test concepts that pharmaceutical companies or device companies would never sponsor by doing very cheap upfront randomization and using population health or registry data to track outcomes. And this is the future of clinical research because the money's drying up to do new things. So I'll show you an example of this. This is a concept I've been working on for about 5 years. I guess it's my next 10 years we'll go into this. It's a concept of remote ischemic conditioning. This will seem a little crazy to you, but basically, if you look at animal models or clinical models of a heart attack, and you cause severe intermittent lack of blood supply to the heart, and then block off the artery, you actually get a smaller heart attack than if you just block off the artery immediately. We don't quite understand why yet. It might be hormonal, it might be nitric oxide, it might be a whole list of things, but it consistently works in every model that's tested. And then the part that makes it really neat is the remote part. So if you put a blood pressure cuff on an animal or a human and inflate it and cause severe arm ischemia, and then the person has a heart attack, it appears to protect them having a smaller heart attack. So this concept is ripe for this type of study that I've just described you. There's not a blood pressure company that's going to pay for this. There's not a device company or a pharmaceutical company that's going to give us money to do this. So this concept is perfect. To summarize what we know in human models, this concept of remote ischemic conditioning causing lack of blood supply to the arm, protecting the heart during a heart attack, has actually been shown to cause smaller heart attacks by both MRI imaging and enzyme release. But to date, there's been no relationship with clinical endpoints. So the what remote ischemic conditioning is in terms of how it's implemented, the paramedics will randomize patients in the field, and they will blow a blood pressure cuff up to 200 millimeters mercury. They'll keep it inflated for 5 minutes, decrease it or deflate it for 5 minutes, and do 4 cycles of this repetitively. So that's the stimulus. And it will be initiated immediately in the ambulance and continued through the time to complete the 40-minute of cycles. And then this will be done within this concept of a randomized registry within our data. And we're going live with this concept as of probably mid-July. They're doing training right now. So we will soon have a model in Canada of using a registry to do a randomized clinical trial. So with that, I've tried to walk you through kind of some of the clinical research we've done, the implementations of that clinical research into a clinical program, and then some opportunities that people like you may be able to influence government's access to data, this concept of registry-based randomized trials. So I look forward to any discussion and questions. Thank you.
Are there any questions from anyone? Tracy?
Really, that's a big deal.
No?
That's good. Thanks.
Okay.
You know,
That's
it's
great.
such a nice
Oh.
presentation that I don't think it should go by without at least a question or comment. Rob, that's just absolutely beautiful work. I really appreciate it. What about us? You know, we're still pretty young. Kerry Moberg wants me to go walking in Banff with him this July. He's in better shape than I am. Should I be getting like a stress test in advance of going, or should I just go and trust to luck? What do you think?
In terms of
Kerry's pretty good at resuscitation, but could he carry one of the, could he carry a syringe?
yeah, so the unfortunate truth is that we have never seen any evidence that we can decrease the risk of having an acute coronary syndrome of heart attack by pre-screening treadmills in asymptomatic patients. So the truth is, if you're exercising currently, have no symptoms, and we run you on the treadmill, we're really not going to make a big difference. But that being said, if you have any concerning symptoms, shortness of breath, chest discomfort, climbing stairs, or anything, then obviously that changes completely, and we need to investigate that. But the routine use of treadmill has not been shown to make a big difference. And that's very much against what the Americans say. They say that everyone over the age of 40 and 45 for women should have a treadmill every 5 years, but it's not evidence-based, and there is some evidence that we actually do inappropriate procedures. So how's that for a sad answer? But phone 911 and take aspirin. And you'll get me on the phone, and we'll treat you in the mountains, because we've even got the Lake Louise and Banff medics online, so it's all good. Okay, thank you.